Good evening, friends. This is Dr. Meenakshi and welcome you to the MCQ Marathon of Pediatrics. So, in this session, we'll be taking up some very important topics which are a must know for you, and I'm sure all of you have gone through these topics. So, this is just meant for a last minute quick revision for you. So, before we start this session, I would request you to please confirm if you're able to see my screen and if I'm audible so that we move ahead. If you have any queries through this session, you can post them in the chat box and I'll try to answer as much as I can. Am I audible and is my screen visible? Yes. Thank you, Vishwanath. Thanks, Partha, Jitendra. So let's start. Right. So we start with a very simple question. At what age the height of a child is half of the adult height? Or adult, So there's a misprint in this question. At what age height of a child is half of the adult height, right? So let us see how do we answer this question. So in order to answer this question, we need to know how much is the height or length of the child at birth and how much the rate at which it is going to increase. So at birth, we know what is the length of a child. So it is around 50 centimeters, right? At 1 year, it is going to become 75 centimeters. At 2 years, it is going to become approximately 90 centimeters. Okay, and till 2 years of age, we call it length, then we call it height, right? And by 4 to 4.5 years, it is going to become 100 centimeters, right? And the usual adult height we know is between 170 to 180 centimeters, right? So half of this 180 is how much? 90 centimeters. And at what age the height is 90 centimeters? Yes. So at what age we saw the height is 90 centimeters? So the height becomes 90 centimeter at the age of, you can see, 2 years. So the best answer out of the given options, let us come back to our question. So very basic information that you need to synthesize the answer to this question, right? So at what age height of a child is half of the adult height? So the answer will be somewhere around 2 years, right? So 20 to 24 months is the best answer out of the given options. Very good. So many of you have answered it as B, Dipinder, Radhika, right? So you are right, Akshay, Manisha. So 20 to 24 months is the best answer to this question. Moving ahead to the next question. What we have here is the mother of a 5-year-old boy who feels that he's too tall for his age, okay? And she brought him to the hospital for evaluation. On examination, his height is how much? 108 centimeter. And arm span was 106 centimeters. Upper segment is to lower segment ratio was 1.2:1. What would be your advice to the mother? Would you ask the mother to go for karyotyping, or would you reassure parents, or you would do echocardiography to rule out Marfan syndrome, or ophthalmological examination and homocysteine levels, right? So in order to answer this question, first we need to know whether this height of 108 centimeter is normal for his age or lesser for his age or more for his age, right? Now actually to do that, we need to plot this height on growth chart. So this is a 5-year-old boy. So for age 5 years or less, you are going to use which growth charts? Yes, waiting for your answers. So for a child who is 5 years of age or less than 5 years of age, the growth chart that we are going to use is the, yes, so it is the WHO growth charts, which is based on the MGRS study, right? Okay, so let us plot this height and see where it is falling. So this, friends, is the WHO growth chart, height for age for boys. You can see it is for 2 to 5 years of age. It is blue in color, so it is a growth chart for boys. This is the WHO growth chart. Okay. Now let us see at 5 years the height was 108 centimeters. Let us try to plot it. So if you can see at 5 years, I'll just minimize it so that you can see here. So at 5 years, okay. At 5 years, the height is 108 centimeters. So 108 centimeters is falling here. Okay, 108 centimeters at 5 years of age. So this is 5 years of age and this is 108 centimeters, right? So it is between 0 and -2 standard deviations or Z score, right? So it is absolutely normal for his age. So this height of 108 centimeter at 5 years of age is absolutely normal, okay? So you need not do anything, any evaluation for this child, okay? And the arm span is also 106 centimeters. So normally the arm span is almost equal to the height of the child, and the difference between the height and arm span normally is less than 3 centimeters, which is again the case here. The difference between them is only 2 centimeters, right? And the upper segment is to lower segment ratio is 1.2:1. So let us see what should be the normal upper segment is to lower segment ratio at various ages before we move on to answer this question. Okay. So before we move on to answer this question, at birth, how much should be the upper segment is to lower segment ratio? So it should be 1.7 to 1.9:1, right? At 3 years of age, the upper segment is to lower segment ratio is going to be 1.3:1. Easy to remember, 3 years, 1.3:1. And by 7 to 10 years of age, the upper segment is to lower segment ratio is going to become 1:1. So at the age of 5 years, the upper segment is to lower segment ratio will be somewhere between 1 to 1.3, which is the case here, right? Now, another thing that if you're not supplied with growth charts in your exam, how do you know the expected height of a child at different ages? So there is a formula that you can use to know the expected height of a child at different ages. So expected height is equal to 6x plus 77 centimeters, where x is the age in years. Okay, x is the age in years. So here the age is 5 years, we know. So here the age is equal to 5 years. So expected height will be how much by this formula? So expected height is going to be 6 into 5 plus 77. That is 107 centimeters, right? So you can see by this method also the expected height is coming to be 107 centimeters, right? So in the given scenario, the child's height is normal for his age, the arm span is normal, the upper segment is to lower segment ratio is also normal. So you need not order for karyotyping, you need to reassure parents that there is nothing wrong with the height of this child. Echocardiography to rule out Marfan syndrome is not required. So Marfan syndrome is a syndrome where there is, tall stature is there, a lot of skeletal abnormalities can be there, like pectus excavatum can be there, long slender fingers, spider leg like fingers called arachnodactyly can be there can be lens dislocation. Similarly, homocystinuria is another disorder where you can get the lens dislocation of the eye and skeletal features resembling Marfan syndrome. And both of these conditions have tall stature, but in the given question the height of the child is absolutely normal, so we just need to reassure patients. Okay, we just need to reassure the parents of the patient. So most of you have answered it correctly. Vinita, Tanisha, Pulakesh, Sapna, right? So most of you have answered it correctly. Very good. So proud of you. Now moving ahead to the next question. What does the following growth chart represent? So what you see here is a chart. Okay, it is a graph basically where what is being done. So here what is there is, there is a line which is increasing in the first 2 years rapidly, and then it is increasing slowly and then becoming static. So what does this chart represent? Whether it represents gonadal growth, that means growth of the genital organs or gonads, or it is representing the growth of lymphoid organs, or it is representing brain growth, or it is representing somatic growth. So in order to answer this question, you need to have some idea about the growth pattern of these various organ systems or parts of the body. How the gonads grow, when is their growth maximum, when is the brain growth maximum, how does somatic growth happen, and when is the lymphoid growth maximum. So let us first discuss the growth pattern of all these 4 organ systems, and then we come to answer this question. Okay. And I'm already seeing that many of you have answered this question correctly already. Very good. Okay. So let us see this graph. So this shows the growth pattern, okay, of various organ systems. So what you see here is, so let us see. So the genital growth, if you look at, the genital growth remains very slow till around 10 to 12 years of age, and at puberty suddenly the growth of the genitals or gonads increases. So that is the pattern which the genital growth is going to follow. Okay. Now, if you look at the general or somatic growth, so general or somatic growth is going to follow a sigmoid shaped pattern. That means in the infancy, the growth is pretty much very rapid the first few years, and then it slows down, and then again at puberty, the growth again accelerates. Okay, so that is how the general growth happens. Now, moving on to neural growth. Brain growth, friends, we know is maximum in the first 2 years of life, and that is why if any insult happens to the brain in the first 2 years of life, it can have lifelong consequences in the form of cerebral palsy, right? So you can see this yellow shaped line is showing the neural growth or brain growth. So maximum in the first 2 years of life, okay, and beyond that it is going to slow down. And how does the lymphoid growth happen? So lymphoid growth, you can see, is again maximum between 4 to 8 years or 4 to 10 years of age. Okay, so this lymphoid growth is maximum in this time. So it has a peak here. Now moving back to our question, in the given question, what does this growth chart show? So it is showing that a large amount of growth is taking place in the first 2 years, and then it is relatively slowing down or plateauing. So this is showing brain growth. Okay, so easy to interpret if your basics are in place. So many of you, again, I can see Avinash, Akhil, Neha, Avinash, Azhar, yes, Nupur, Priyank. So many of you, Sachin, you've answered this question correctly, right? So moving ahead. Now, very simple question again. Again, stressing the important point that you need to know about dentition in children. Very basic but very important. Lot of true false questions or one liners, things like that can come from here. Which is the first permanent tooth to erupt in a child? Very simple. We all know there is a temporary dentition and there is a permanent dentition. The temporary teeth is called primary dentition. The secondary dentition or permanent teeth. Okay, secondary dentition is the permanent teeth. So the primary dentition begins at, so when does the first tooth erupt in the child? So first tooth erupts in a child at the age of 6 to 7 months, right? While first permanent tooth, when does first permanent tooth erupt in a child? The first permanent tooth erupts usually at the age of, yes, 6 years, right? Which is the first tooth to erupt in a child? So the first tooth to erupt in a child is the lower central incisor. Very good, Radhika. And I can see many of you have answered it correctly. So first milk tooth we are talking about. Okay, so this primary dentition is the milk teeth or temporary teeth. So the first milk tooth to erupt in the child is a lower central incisor. But the first permanent tooth to erupt in a child, which is the first permanent tooth to erupt in a child? It is the first molar, right? Okay, the last milk tooth to erupt in the child is the second molar, while the last milk tooth to erupt in a permanent dentition is the third molar or the wisdom tooth, which might not erupt in some of us also, right? Now the primary dentition usually completes by around 2.5 to 3 years, while the secondary dentition completes at 12 years except the third molars, which come usually between 18 to 25 years of age, or they may not erupt also. So except third molars. So the total number of teeth in primary dentition we know is 20, and in secondary dentition it is 28 to 32 depending on how many third molars have erupted, right? So moving ahead to answer this question, which is the first permanent tooth? So see, read the question very carefully. So it is asking the first permanent tooth and not the first tooth. Okay, so which is the first permanent tooth to erupt in the child? So what will be the best answer? Yes, the first permanent tooth to erupt in the child. So it is not asking the first tooth to erupt in the child. So the answer is not the lower central incisor. Read the question very carefully. Don't be overconfident and jump to answer the question without reading it carefully. So the best answer to this question is yes. So Sapna, Tanisha, Pulakesh, Akhil, Neha, Nidhi, okay, Akshay, a lot of you have answered it correctly. So it is the first permanent tooth is the first molar. Yes. So it's the first molar. Right, you are. Okay. Now we also need to know a little bit about delayed dentition. When do you call it delayed dentition? So we call it delayed dentition when no teeth, okay, when no teeth has erupted till what time? 13 months age. Then we call it delayed dentition. Okay. So normally a milk tooth appears by 6 to 7 months, but when no teeth has erupted till 13 months of age, we call it delayed dentition. Important causes of delayed dentition are, so etiology or important causes of delayed dentition, sometimes asked in various case scenarios. So it can be familial, in a family everyone is having teeth late. It can be due to rickets. Okay, it can be idiopathic, or it can be due to incontinentia pigmenti. Okay, idiopathic. Some endocrine causes. Which endocrine causes? So endocrine causes can be like hypothyroidism, hypoparathyroidism, hypopituitarism. So 3 hypos can be there. Down syndrome, there can be delayed dentition. Okay, Down syndrome. And there's a condition called cleidocranial dysostosis, where there is partial or complete absence of clavicles. So cleidocranial dysostosis, the child is able to touch both of his shoulders with each other anteriorly, which we are not able to do, right? So cleidocranial dysostosis is a condition where there is large anterior fontanelle and delayed closure of anterior fontanelle. The teeth, there is delayed dentition. There is also supernumerary teeth. That means their teeth in adulthood, they can have more than 32 number of teeth can be there. Okay, so all these are features of cleidocranial dysostosis, which has autosomal dominant inheritance. So you can get questions on it. Moving on to the next question, match the following. Again, a very simple question based on the very important developmental milestones. So you have to match when does social smile, pincer grasp, walking 1 to 2 steps, and transfers objects come. Okay, so let us first go quickly through some very important developmental milestones, and then we move ahead to answer this question, right? So when does neck control come? So neck control usually appears by 3 months of age, but complete neck control may take 4 to 5 months to appear. Sitting with support. So gross motor milestones, the sequence is very clear. Sitting, then standing, then walking. Everything with support first, without support later. So sitting with support, come on, rapid fire. Sitting with support comes at 6 months of age. And sitting with support means sitting in tripod position. That means with the support of his or her own hands. Okay. Sitting without support will come at around 8 months of age. Crawling will also come at around 8 months of age. Creeping will come around 10 months of age. Standing with support will come at around 9 months of age. Standing without support 12 months of age. Walking with support around 12 months of age. Walking without support around 13 months of age. And riding a tricycle, very important milestone, comes at around 3 years of age, right? Moving ahead to some very important fine motor milestones. So hand regard is a milestone. When does it come? So it comes at 3 months of age. Bidextrous grasp means holding with both hands is going to come at 5 months of age. Palmar grasp or unidextrous grasp is going to come at 6 months of age. Transferring objects from one hand to another comes at around 7 months of age. Immature pincer grasp, where the child takes the help of the hand and the other fingers like this. So immature pincer grasp comes at around 9 months. Mature pincer grasp like this, using the thumb and index finger, comes at around 12 months of age. Scribbling spontaneously, 15 months. Tower of 6 to 7 cubes, 2 years. So number of cubes put in tower is approximately equal to age into 3. So 2 years, 6 to 7 cubes. 3 years, 9 to 10 cubes in tower. Handedness appears by around 2 years or 24 months, and handedness gets established. That means whether the child is a left-handed or right-handed person gets established by 3 years or 36 months of age. Drawing skills. Very easy to remember. A line has got how many ends? 2 ends, right? A line has got two ends. So copying a straight line, horizontal or vertical, comes at 2 years. Now rectangle has got 4 vertices. So copying a rectangle comes at 4 years of age. Similarly, copying a cross also comes at 4 years of age. Okay. Now copying a circle, the number 3 is rounded in shape. So copying a circle comes at 3 years of age. And copying a triangle comes at 5 years of age, because now the child can draw oblique lines. And because the child can draw oblique lines, the child can also copy this multiplication sign or a tilted cross at this time. Moving to important social milestones. Social smile, very important. So it is a quick rapid revision for you. 2 years of age. Mirror play, that means social smile comes at 2 months of age. Okay, 2 months of age. Mirror play, that means smiling and vocalizing at his or her own mirror image, around 6 months of age. Stranger anxiety, 7 months. Waves bye-bye, very important milestone, comes at 9 years of age. Plays peekaboo around 10 months of age. So waves bye-bye, 9 months of age, very important. Okay, plays peekaboo 10 months of age. Plays a simple ball game at around 12 months of age. When does the child point to objects? So points to objects at 15 months. Domestic mimicry, 18 months. Dry during daytime, again 18 months. Parallel play, 2 years, and joins in play, 3 years. Moving to quickly some important language milestones. The child vocalizes 2 months, cooing around 3 months, monosyllabic babbling 6 months, bisyllabic 9 months, 2 to 3 words with meaning at 1 year of age. Remember 1, 2, 3. So 1 year, 2 to 3 words with meaning. Jargon speech 15 months, 10 words with meaning at 18 months, 2 word sentences 2 years, 3 word sentences 3 years. So number of words put in sentences is approximately equal to the age in years. Moving back to our question. So match the following. So social smile comes at what age? Yes. So social smile usually comes at 1 to 2 months of age. Pincer grasp is going to come at what age? 9 to 11 months of age. Walks 1 to 2 steps at 12 to 13 months of age. And transfers objects at 6 to 7 months of age. So very important milestones we need to remember to answer these questions based on the normal developmental milestones. Okay. So moving ahead. What are the components of kangaroo mother care? So time and again, so many times you've got this repeat question on kangaroo mother care. Again, a very basic thing, but you do get questions from here, so you must need to remember. So what are the components of kangaroo mother care is being asked. So kangaroo mother care we know is a it is a thing where the baby is kept in skin to skin contact with the mother inside the clothing of the mother. So the three components of kangaroo mother care are kangaroo position, kangaroo nutrition, and early discharge from hospital. Okay, so let us see the options one by one. So use of radiant warmer, is it a part of kangaroo mother care? No. So first option is incorrect. Prevention of hypoglycemia, early discharge from hospital. Second option B, exclusive breastfeeding. Okay. Warmer care, again warmer care is not there in kangaroo mother care, so it is also incorrect. Yes, waiting for your answers. So C, skin to skin contact, exclusive breastfeeding, and early discharge from hospital is the correct answer. And I can see Ashwin, Sachin, Gyanendra, Pulakesh, Nupur, Sapna, Nidhi. The list is endless. So Shubham, Avinash, so Vicky, Vinitha, so many of you have answered it correctly, though some of you have fumbled upon the choices. D, skin to skin contact, exclusive breastfeeding, and prevention of infection. Though kangaroo mother care does help in prevention of neonatal sepsis, but this prevention of infection as such is not a component of kangaroo mother care. So read your question very carefully. What exactly is it trying to answer to ask? Okay. So basically this kangaroo mother care is indicated in all stable. The word stable is very important. If a baby is on oxygen or on inotropes, is in shock, obviously we are not going to advise kangaroo mother care. So it is recommended for all stable low birth weight babies. And what are the advantages because of which it is recommended? So advantages are it will decreases the risk of hypothermia. Okay, it decreases the risk of neonatal hypothermia. It decreases the risk of neonatal sepsis. It has been seen to decrease the risk of neonatal mortality. Okay, and it helps in early discharge from hospital. And those babies who have got kangaroo mother care, it has been seen they have higher exclusive breastfeeding rates. So more and more breastfeeding is there, higher exclusive breastfeeding rates and better growth. Okay, higher exclusive breastfeeding rates and better growth parameters. Okay, so that's about kangaroo mother care. Now moving ahead, what dose of dexamethasone is given to a pregnant lady for fetal lung maturity? So this question is asking again about a very important entity from which you often get questions, that is the antenatal corticosteroids. So we know antenatal corticosteroids, whether it be dexamethasone or betamethasone, the antenatal corticosteroids is a very important topic from which you often get questions. So this antenatal corticosteroids is indicated for all mothers. So indicated for mothers expected to deliver between 24 to 34 weeks of gestation. Okay, weeks of gestation it is indicated, right? Now which antenatal steroid? You can give either dexamethasone or betamethasone, and the dose of both is important. So it can be either betamethasone or dexamethasone. Okay, so betamethasone, what is the dose? So betamethasone, just a moment. Yes, so betamethasone, what is the dose? The dose of betamethasone is 12 milligram intramuscularly, 2 doses 24 hours apart. So very easy to remember, 12 into 2 is 24. So betamethasone, the dose is 12 milligram intramuscularly, 2 doses 24 hours apart. And dexamethasone, what is the dose? So dexamethasone, each dose is half the dose. So dexamethasone dose is how much? 6 milligram, 4 doses 12 hours apart. Okay. So very easy to remember. Now betamethasone has been seen to be more neuroprotective, and though the efficacy of both of them is similar, but dexamethasone is more cheaper and easily available, so that is why it is recommended in the Government of India guidelines. Okay. So that is antenatal steroids, and it should be given to all mothers who are expected to deliver preterm. And of course, you cannot give it if there is infection in the form of chorioamnionitis, then we avoid it. What are the advantages of antenatal steroids because of which it is recommended? So the advantages of antenatal steroid is it decreases the risk of intraventricular hemorrhage, it decreases the risk of necrotizing enterocolitis, okay, and it also decreases the risk of neonatal mortality. And of course, it decreases the risk of respiratory distress syndrome or hyaline membrane disease. So all these are advantages of antenatal steroids. But remember, antenatal steroid does not decrease the risk of neonatal jaundice. Okay. So coming back to our question, what dose of dexamethasone is given to a pregnant lady for fetal lung maturity? So it is not 12 milligram, 2 doses. So 12 milligram we know is the dose of betamethasone and not dexamethasone. 6 milligram, 2 doses, no, we know 4 doses of 6 milligram is required. 12 milligram, 4 doses, no, 12 milligram is not the dose. So the best answer is 6 milligram, 4 doses, 12 hours apart. And I can see Shroshta and Mednomic, Neha, Dr. AJ, Sapna Negi, Sapna Sharma, Neha Srinivas. So many of you have answered this correctly, right? Moving ahead to the next question. Again, a very, very important concept that we need to remember. A 5-day-old newborn. 5-day-old newborn presents with icterus extending up to the lower abdomen. Okay. And all of the following would indicate physiological jaundice of newborns except. So let us first see how do you distinguish physiological jaundice of newborn from pathological jaundice, and then we move on to answer this question. So let us see how do you distinguish physiological jaundice from pathological jaundice, right? So physiological jaundice, what happens? It never appears in the first 24 hours of life. So never appears. The icterus in physiological jaundice never appears in first 24 hours of life. Okay. But in pathological jaundice, the jaundice may appear. In pathological jaundice, the jaundice may appear in first 24 hours. Okay. In first 24 hours. Right. Now physiological jaundice. The physiological jaundice, what happens? It is never very severe. Right. So in physiological jaundice, the palms and soles are never stained yellow. So palms and soles not stained yellow. Okay. While in pathological jaundice, the palms and soles may be yellow. Palms and soles may be yellow. Right. Physiological jaundice is always unconjugated. Okay. Physiological jaundice is always unconjugated. That means you do not get high colored urine. Okay, urine is not high colored because unconjugated bilirubin cannot pass through the urine, it cannot pass. Okay, so unconjugated bilirubin cannot pass, so you cannot get high colored urine. So physiological jaundice, no high colored urine. So diaper is not stained yellow. Okay, no high colored urine in physiological jaundice. While pathological jaundice, you may get high colored urine and pale stools. Okay. So may be conjugated or unconjugated, right? And physiological jaundice, what happens? Physiological jaundice usually subsides by 2 to 3 weeks of age. So clinical jaundice and physiological jaundice usually subsides by 2 to 3 weeks age. But pathological jaundice may persist for a longer time. Okay, may persist for longer time, right? Okay. So now moving back to answer our question. So what we have is a 5-day-old newborn with icterus up to the lower abdomen. All of the following would indicate physiological jaundice of newborn except palms and soles not stained yellow. So is it a feature of physiological jaundice? Yes, it is. High colored urine staining the diaper of the baby. Do you get it in physiological jaundice? No, we do not, because physiological jaundice is always unconjugated, and unconjugated bilirubin cannot pass through the urine. Now, no clinical jaundice in first 24 hours. Is it a feature of physiological jaundice? Yes. Resolution of clinical jaundice by 2 to 3 weeks of age. Is it a feature of physiological jaundice? Yes, it is. So all of the following would indicate physiological jaundice of newborn except. So the best answer to this question is high colored urine staining the diaper of the baby. So that is not a feature of physiological jaundice. Okay, right. So moving ahead. So many of you have answered the question correctly. So the correct answer is B, and I can see Himanshu, Akhil, Sapna, Keshav, Monica, Neha, Srinivas, okay, Srinija. So many of you have answered it correctly. So this is again a very, very important topic. You do get questions either from this, neonatal jaundice or hemolytic disease of newborn or phototherapy related questions. So a very, very important topic, must know area for you. Moving ahead, all of the following are true about neonatal seizures except. Most common type is subtle seizures. Yes, the most common type of neonatal seizure is subtle seizure indeed, correct. The neonatal seizures can be caused by hypoxia or hypocalcemia. Yes, hypoxia and hypocalcemia are very important cause of neonatal seizures. It can also be caused by hyponatremia, hypernatremia. Okay, then neonatal sepsis, meningitis can cause seizures. Pyridoxine is used as a treatment in refractory cases. Yes, in refractory cases of neonatal seizures which is not responding to antiepileptics, we usually give a trial of pyridoxine. What is the drug of choice for neonatal seizures? Yes, waiting for your answers. What is the drug of choice for neonatal seizures? Yes, anyone? Let us see who is going to answer. The drug of choice for neonatal seizures is phenobarbital. Okay, phenobarbital, right? Now the fourth option, the abnormal movements stop when that particular limb is restrained. So in seizure, do you think that abnormal movement is going to stop if you hold that limb? No, it doesn't stop. So D is the correct answer. Okay, all of the following are true about neonatal seizures except is the question. So in which condition, the movement stops when you hold that limb or restrain that limb? What is that called? So that condition where the movement stops when you restrain the limb is known as jitteriness. Okay, it is called jitteriness. Okay, so how do you distinguish seizures from a very common condition in newborns, that is jitteriness? How do you differentiate? Let us see. So what happens? Seizure versus jitteriness. So one difference we already told. In seizure, what happens? Even if you hold that limb, the movements are going to continue. Okay, so seizures are not stimulus sensitive. That means even if you hold that limb, the movement that is happening in seizures is going to continue. But jitteriness is stimulus sensitive. That means if the child is having jitteriness of one particular limb, the neonate or infant, you hold that limb, that movement stops. So jitteriness is stimulus sensitive, right? What else? In seizures, you usually have this jerky clonic movements. So there's a fast component and a slow component, fast component and a slow component. So usually it has a fast and slow component. But in jitteriness is more like, tremors. So where both the movements, both the alternating movements are equal in speed. So alternate movements of equal speed, just like tremors. So alternate movements of equal speed is there in jitteriness. What else? In seizures, it is usually associated with some ocular phenomenon. There can be some uprolling of eyes or deviation of eyes to one particular side. So it is usually associated with some ocular phenomenon. While jitteriness is usually not associated with ocular phenomenon. Okay. So we already answered our question. The best answer is D, that is the abnormal movement stop when that particular limb is restrained. So that is not true about neonatal seizures. Moving ahead to our next question, which of the following is true about congenital CMV infection? So congenital CMV infection is another very important topic, a favorite of the examiners, often asked in your exams. So 20 to 30% of CMV infections are symptomatic at birth. Is that true? No, I am afraid it isn't. Okay. So almost 90%. So if we are talking about congenital CMV infection, 90% cases are asymptomatic. Only 10% are going to have some symptoms. So 90% cases are asymptomatic. So only 10% of the babies are going to have some symptoms. So the first statement is false. And our question is asking which of the following is true about congenital CMV infection. Okay. The next option, triad of sensory neural hearing loss, cerebral calcification and dental enamel hypoplasia is seen. So there's no such triad in CMV, though sensory neural hearing loss is quite commonly seen. There may sometimes be cerebral calcification. Dental enamel hypoplasia is rarely a feature of congenital CMV. So there's no such triad or association with all these three in congenital CMV. Okay. The next option C, child is immune to transplacental transfer if mother is CMV IgG positive. Is that true? So if the mother acquires, so during pregnancy, if the mother acquires CMV infection for the first time versus if the mother is already infected with CMV before, then there's a difference in the rate of transmission. Okay, so during pregnancy, if there is a primary CMV infection, then what will happen? The mother will have CMV IgM positive during pregnancy, and the risk of transmission to the baby, okay, is almost 30%. While if the mother has secondary CMV infection during pregnancy, that means mother was previously infected with CMV sometime, she already has CMV IgG positive, okay. In that situation, the risk of transmission of CMV infection to the baby is 1 to 2%. So it is not zero. The risk of transmission is less if the mother has secondary CMV infection. And if the mother is CMV IgG positive, the risk of transmission is 1 to 2% only, but it is not zero. The baby can still have congenital CMV infection if the mother is having CMV IgG positive, though the risk of transmission is less. But if you look at the absolute numbers, secondary CMV infection is much more common in pregnancy than primary CMV infection. So if you look at absolute numbers, actually, secondary CMV infection in the pregnancy causing congenital CMV in the baby, absolute number wise, it is very common. Okay. So, by examining our option once again, child is immune to transplacental transfer if mother is CMV IgG positive is not correct. The risk of transmission we know is only 1 to 2%, but it is still there is a risk of transmission. Most children who develop sensory neural hearing loss later in the life are asymptomatic at birth. Yes, this is the correct option. So many babies, most of the babies who develop sensory neural hearing loss because of congenital CMV infection may remain asymptomatic at birth. In fact, congenital CMV infection is the most common acquired non-syndromic cause of sensory neural hearing loss in children. So congenital CMV infection is a very important cause of acquired non-syndromic sensory neural hearing loss in children, and you must remember that. So D is the best answer to this question, right? Very good. Again, Sapna, Avinash, Akhil, Monica and Rashmi, Brijendra, Gamma Knife, whatever your name is. So moving ahead to the next question, which of the following statements are false about poliomyelitis? So we have to find out the false statements about poliomyelitis. Paralytic polio is mostly asymptomatic. So before answering this question, let us discuss a little bit about the clinical features of poliomyelitis. Okay. So clinically, poliomyelitis can present in various forms. 90 to 95% cases have inapparent infection. Okay, 90 to 95% cases have inapparent infection. That means you will not be able to make out only that the baby is having infection due to poliovirus. So inapparent infections, right? 5% cases have abortive poliomyelitis. 5% cases have abortive poliomyelitis. That means they have an influenza like flu-like illness with fever, malaise, etc. So abortive poliomyelitis. Okay. 1% of the babies are going to have non-paralytic poliomyelitis. 1% cases are going to have non-paralytic poliomyelitis, where they are going to have, this nuchal rigidity can be there, bowel bladder involvement can be there, but this acute flaccid paralysis will not be there. So non-paralytic poliomyelitis you can see in 1% cases. While in 0.1% of cases of polio infection only, you get paralytic poliomyelitis, which can be bulbar palsy, or there can be spinal involvement can be there. Okay. Also, 0.1% cases only have paralytic poliomyelitis. Okay. And of course, they will have clinical manifestations. Now, moving back to answer our question. So which of the following statements are false about poliomyelitis? Paralytic poliomyelitis is mostly asymptomatic. How can paralytic polio be asymptomatic? So inapparent infection, if it is there, that is asymptomatic. Paralytic polio is not asymptomatic. Spastic paralysis is seen is again false. We all know from our PSM days that acute flaccid paralysis is that is seen in poliomyelitis. So again, this statement is also false. Now, IM injections and increased muscular activity lead to increased paralysis. Yes. If you excite the muscles in some way by giving injections or increase muscular activities there, it will increase the paralysis in poliomyelitis. Yes, that is correct. Polio drops and pulse polio immunization is given in only less than 3 years old children? No. We know it is given in all children less than 5 years of age. And nowadays the oral polio vaccine that is used is bivalent. Which two strains of polio virus are covered in that? So P1 and P3. So these two are covered in that, right? So you can see that the statements 1, 2 and 4 are false. So which of these are false? So the answer is A. Again, I can see Monica, Vinash, Pulkesh, Himanshu, Vinita, Neha Fareen, Tanisha, Yashika, Brijendra, Ghanshyam, Akhil. So very proud of you. Again, A is the best answer here. Moving ahead to the next question. What you have here is a 2-year-old child. Okay. You have a 2-year-old child who has steroid-dependent nephrotic syndrome who is on prednisolone for last 3 months. Which of the following is false about his vaccination? So, if a child is on steroids, that means we will treat that child as an immunocompromised child and we will vaccinate accordingly. So first let us discuss what should be the vaccination strategy in an immunocompromised child or a child on steroid, and then we'll move to examine the options and answer the question. Okay. So if the child is on oral steroids like in nephrotic syndrome at a dose of 2 mg per greater than equal to 2 mg per kg per day or greater than equal to 20 mg per day. Okay. So if a child is on this dose of oral steroid, then what are the recommendations for vaccination? Avoid all live vaccines. Avoid all live vaccines till 1 month after discontinuation of steroids. So when you stop steroids for 1 month, only then you think of giving live vaccines. So till 1 month after discontinuation of steroids, you avoid live vaccines. What else? You can give all killed vaccines. All killed vaccines can be given. Right? What else? Especially try to give pneumococcal vaccine in these children before initiating steroids if possible, because increased risk of infection is there in these children. So pneumococcal vaccine to be given ideally before initiating steroid if possible. Okay, before initiating steroid if possible. Annual influenza vaccine should be given because again these children are immunocompromised, more risk of infection. So better to cover them with annual influenza vaccine as well. Siblings of these children should not be given oral polio vaccine, live transmissible vaccines like OPV. Because what will happen if a sibling gets OPV, the baby is going to excrete that OPV in the stool. And if the immunocompromised child comes in contact with the polio virus, he or she can have disease. Okay. So siblings, avoid OPV, avoid live transmissible vaccines like OPV in the siblings. So avoid OPV in siblings. So that is the recommendation if a child is on oral steroids like a child of nephrotic syndrome. But remember, if a child is on topical steroid, some steroid ointment or inhaled steroid due to bronchial asthma, inhaled Budicort and all, then there is no contraindication to any vaccination. You can vaccinate like a normal child. Okay. Moving back to our question. Okay. So a 2-year-old child who has steroid-dependent nephrotic syndrome who is on prednisolone for last 3 months, which of the following is false about his vaccination? So pneumococcal vaccine should be given before commencing the treatment. Yes, it is true. Siblings should not be given OPV. Yes, we know that siblings should not be given live transmissible vaccines. It is true. Give all killed vaccines. Yes, all killed vaccines can be given to these babies. Give all immunization according to the schedule. This is wrong. We need to avoid live vaccines until 1 month after stopping of the steroids. So D is the best answer to this question. Okay. So let us see who all have answered it correctly. Akshay Rajput, AG, Ghanshyam, Shrinja, Neelam, okay, Dhyaneshwar, Saurav, Mohan, Tanisha, Ghanshyam, Vinutha, Shubham, Bharti. So many of you have answered it correctly. Very good. Moving ahead to the next question. So this question is asking that 2 open vials of pentavalent vaccine and 1 open vial of MR vaccine is given back after an immunization session. What should be done with those vials? Should you discard both the vials, or pentavalent can be used, MR discarded, or MR used, pentavalent discarded, or both vials can be used? So basically this question is asking you about a very important concept that has come up recently in immunization, that is the open vial policy. Now, according to the open vial policy, this open vial policy allows the reuse of partially used multi-dose vials of certain vaccines. Multi-dose vials of certain vaccines in the subsequent immunization sessions, okay, till next 4 weeks, provided certain conditions are met. What are those conditions? So provided certain conditions are met. What conditions are met? Let us see first, and then we'll see which vaccines follow the open vial policy. So open vial policy allows the reuse or partially used multi-dose vials of certain vaccines till the next week in the subsequent immunization sessions, provided certain conditions are met. And what are those conditions? The expiry date of the vaccine should not have passed. Vaccines have been stored again under appropriate cold chain condition. Okay. Vaccine vial septum has not been submerged in water or contaminated in any way. Aseptic technique has been followed to withdraw the vaccine. And VVM, the vaccine vial monitor, has not reached across the discard point. So another point I would like to highlight here is a VVM is the very important topic often asked in your MCQs. Okay. So this open vial policy, you can see, is not applicable for which vaccines? It is not applicable for the freeze-dried vaccines. So this open vial policy is not applicable for freeze-dried vaccines like BCG, measles or MR, Japanese encephalitis, rotavirus vial. So in these vials, you will see that the VVM, the vaccine vial monitor, is on the cap. And in these vaccines, the open vial policy is not followed. While in rest of the other vaccines like pentavalent vaccine, like the polio vaccine, open vial policy is followed. And you can see the VVM or the vaccine vial monitor here. Okay. So a little bit more about VVM. So vaccine vial monitor is a thermosensitive label, and you can use a vaccine if the vaccine vial monitor shows the inner square is lighter in color as compared to the outer circle. But if the inner square is same in color, or if the inner square is darker compared to the outer circle, you do not use it. So very important, VVM. And in VVM sometimes a number is written. Suppose it is written VVM 8. VVM 8 means that the vaccine can be, vaccine will remain effective if it is stored at room temperature for 8 days. The vaccine is still going to remain effective only for 8 days, but beyond that it will reach the discard point. So this number also sometimes may be asked, what is the significance? So moving back to our question, waiting for your answers. So 2 open vials of pentavalent vaccine, 1 open vial of MR vaccine is given back after an immunization session. What should be done with those vials? Both should be discarded? No. Pentavalent can be used and MR must be discarded? Yes. Pentavalent follows the open vial policy, so that can be used, but MR vaccine needs to be discarded. Yes. So who all have answered correctly? Let me see. Nupur, Shubham, Ghanshyam, Rashmi Priya, Ishwarya, Yashika, Avinash, Roshta, Brijendra, Pulakesh. The list is again endless. Very good, guys. So moving ahead to another important question. So arrange the following structures of fetal circulation in descending order of oxygen saturation. Again, fetal circulation is a very important concept that we need to have. Okay. So umbilical vein, umbilical artery, aorta, inferior vena cava. So let us see a little bit about the fetal circulation in gist, and then we move on to answer this question. So the source of oxygen for the fetus, we know what is the source of oxygen. It is the placenta. From placenta comes out the umbilical vein. So maximum oxygen saturation in the body of fetus is in the umbilical vein. So umbilical vein has an oxygen saturation of around 80%. So umbilical vein has got the maximum oxygen saturation of 80%, right? Now blood from the umbilical vein is going to go to the ductus venosus. So ductus venosus has got the next higher, so little less than 80%. And then this blood is going to go to the inferior vena cava. And the oxygen saturation in inferior vena cava is around 70%. Okay. Then the blood is going to reach the heart, it is going to reach the right ventricle and the left ventricle, and we know from the left ventricle the aorta is going to come out, right? So aorta will have an oxygen saturation of around 65%. So aorta will have next around 65%. Okay, and then this the blood is going to supply to all parts of the body, and the deoxygenated blood is going to go back to the placenta via the umbilical arteries. So the umbilical arteries have got the minimum oxygen saturation in the body of fetus. So these umbilical arteries are going to have the minimum oxygen saturation in the body of fetus. So you can see the maximum oxygen saturation is there in umbilical vein, followed by ductus venosus, followed by inferior vena cava, and then the aorta, and then the umbilical arteries have got the minimum oxygen saturation. So moving back to answer our question. So in the descending order of oxygen saturation, so we see that the maximum oxygen saturation is there in the umbilical vein. So one should come first, okay, like in these two options. Then the next will be after umbilical vein, the next higher oxygen saturation is in inferior vena cava. So you should have 1 followed by 4 like you have here, and then will come the aorta, and then will come the umbilical artery, which has got the least oxygen saturation. Umbilical vein has got the highest oxygen saturation in the body of fetus, and they can come as independent questions as well. So the best answer to this question is D. And I can again see Neha Srinivas, Ghanshyam, Sapna, Akhil, Rupak, Pulakesh, Shubham, Ishwarya, Arvind Samalia, Vinitha, Himanshu, Brijendra, Shifali, Ganesh Roy, Partha, Madhuri. So very good, awesome guys, right? Moving to the next question, in which congenital heart disease all the 4 chambers have equal oxygen saturation of blood? In tetralogy of Fallot, do all the chambers have equal oxygen saturation? No. In tetralogy of Fallot, you know, the right atrium is going to receive the deoxygenated blood from superior vena cava and inferior vena cava, so lesser oxygen saturation. Left atrium is going to receive the oxygenated blood from the lungs, so higher oxygen saturation. So all chambers do not have equal oxygen saturation in tetralogy of Fallot. Total anomalous pulmonary venous connection. So I'll tell you a little bit about this condition, total anomalous pulmonary venous connection. What happens in this condition is, so if this is the right atrium, left atrium, right ventricle, left ventricle. So you can see the right atrium, right ventricle, right atrium, left atrium, right ventricle and left ventricle. Now what happens in total anomalous pulmonary venous connection is, the pulmonary veins, instead of draining in the left atrium, they will drain in the right atrium. So in the right atrium, what is happening? The superior vena cava is draining in the right atrium. The inferior vena cava is also draining in the right atrium. And the pulmonary veins carrying oxygenated blood is also draining in the right atrium. So right atrium is getting this mixed blood, okay? And this blood via the foramen ovale or atrial septal defect is going to go to left atrium, and this blood only is going to go, so this blood is going to go to the left atrium, and this blood is going to go to the right ventricle and left ventricle as well. So you can see all the chambers of heart have got equal oxygen saturation in total anomalous pulmonary venous connection, because the blood from the systemic circulation as well as the blood from the lungs, all of it is coming together to the right atrium, getting mixed and is circulated to all parts, all chambers of the heart. So total anomalous pulmonary venous connection, all the chambers of the heart have got equal saturation. While in transposition of great arteries, there is a parallel circulation. So the right side, the right atrium and right ventricular blood is going to the, so from the right ventricle, normally what happens? Pulmonary artery comes out. But in transposition of great arteries, from the right ventricle, aorta will come out. So it will go to the body and then the deoxygenated blood. So right side of the heart will go on having deoxygenated blood. While in TGA, the left side of the heart will go on having oxygenated blood. Okay. So they will have different oxygen saturations. And in ventricular septal defect also, we know right side of the heart is going to have lesser oxygen saturation. Left side of the heart is going to have higher oxygen saturation. So a congenital heart disease in which all 4 chambers have equal oxygen saturation of the blood is total anomalous pulmonary venous connection, and we know why. Here again, I would like to stress that related to these congenital heart disease, you also get questions based on their X-ray findings. Very, very important. We know in tetralogy of Fallot, you get a boot-shaped heart or a core and sabot appearance, right? In total anomalous pulmonary venous connection, what do you get? So in total anomalous pulmonary venous connection, in the supracardiac type especially, the supracardiac TAPVC, what we get is a snowman appearance, or it is a cottage loaf heart also. It is called snowman or figure of 8 or cottage loaf appearance of heart. Okay, loaf appearance of heart. Transposition of great arteries, we know egg shaped heart is there. Okay, right? And coarctation of aorta, there is notching of inferior margin of ribs. Epstein anomaly, you have a box shaped heart, and so on. Very important. Right, moving ahead, a 1-year-old child presented with fever and splenomegaly. In which condition splenomegaly is not present? So you can get an elaborate case scenario here. I want to stress upon the point that in leukemia and lymphoma, you will get splenomegaly because there is deposition of malignant cells in the reticuloendothelial system, in the bone marrow. In Gaucher disease also, there is deposition of Gaucher cells, okay, in the bone marrow, and you get huge splenomegaly in Gaucher disease. Splenohepatomegaly, the spleen comes and crosses the midline, okay, crosses the umbilicus. So in these three conditions you get splenomegaly, but you do not get splenomegaly in aplastic anemia. So in which condition splenomegaly is not present? So the best answer here is aplastic anemia. Aplastic anemia, you have pancytopenia without splenomegaly. So if you are getting a case scenario where you are getting pancytopenia without splenomegaly, think of aplastic anemia. Okay. So again, Shubham, Yashika, PK Barik, Arun, Robin, Gyanendra, Ghansham, Chaitanya, Shroshta, Arun, Shubham, Pulkesh, Avinash, Partha Naskar. C is the right answer. Yes. Moving ahead to another very important topic, which is a must know area for you. A pre-morbidly normal 9-month boy weighing 8 kgs presented with loose stool for 2 days. 8 to 10 times per day, watery, no blood or mucus in stool. So this appears to be a case of acute diarrhea. It is not dysentery because there is no blood or mucus in stool. It is acute because it has been there only for 2 days. If it would have been there for more than 14 days, we would have called it persistent diarrhea with an acute onset. He does not have any fever, but he is restless, irritable, thirsty, eager to drink. His mother felt that the eyes of the child appeared slightly sunken at that time as compared to his normal status. However, his pulses were normal, volume and peripheries were warm. How much and what fluid will you give in the first hour to this baby? So this again tests a very important concept, how to assess dehydration in a case of diarrhea, what is the management of acute diarrhea in children, how much fluid needs to be given, what fluid needs to be given. Very, very important topics all in itself. You usually get a question or two from this topic, right? So how to assess dehydration in a child with diarrhea is very important. From a given case scenario, you need to know. So assessment of dehydration in a child with diarrhea, there can be either no dehydration or some dehydration or severe dehydration. Now sensorium will be normal in case the child has no dehydration. In some dehydration, the child will be restless or irritable, like the given case scenario, restless or irritable. While in severe dehydration, the child will be lethargic, okay, lethargic, floppy, flaccid. Thirst will be normal again in no dehydration. In some dehydration, the child is thirsty, very thirsty and eager to drink. Thirsty and eager to drink. Right? While in severe dehydration, the child is so sick, the child is not able to drink. Drinks poorly or not able to drink water or ORS. Okay? Skin pinch goes back normally in no dehydration. But in some dehydration, the skin pinch goes back slowly because the skin turgor is less slowly, but in less than 2 seconds. While in severe dehydration, the skin pinch goes back very slowly, taking more than 2 seconds to go back to normal. Right? Mucosa is again normal, moist in no dehydration, dry in some dehydration, very dry in severe dehydration. Eyes normal in no dehydration. It can be slightly sunken in some dehydration, very sunken in severe dehydration. Tears present in no dehydration, absent in some dehydration and absent in severe dehydration. So you can see if the patient has 2 or more signs, including at least one sign in an inverted commas. So the important signs are the sensorium, thirst and skin pinch. Like given in this case scenario, we can see that the child is restless and irritable. Okay, restless and irritable. So restless and irritable is a feature of some dehydration. Again, the child is thirsty and eager to drink and his eyes are slightly sunken. So thirsty and eager to drink, eyes slightly sunken, all these are features of some dehydration. So our child in the question has some dehydration. Now let us see how much fluid do we need to give in various cases of dehydration? If there is no dehydration, do you need to give extra fluid? Yes, we need to give extra fluid to prevent dehydration. How much? We need to give 5 to 10 ml per kg per loose stool. Okay. So to prevent dehydration, and we give it in the form of ORS, oral rehydration solution. Some dehydration, we need to give 75 ml per kg fluid over 4 hours. If the child is able to take orally, we give it as ORS. If the child is not able to take orally, that means the child has persistent and recurrent vomiting, you may need to give it as IV fluid. Severe dehydration, we need to give 100 ml per kg, okay, and it is given as IV fluid, right? Plus ORS you have to give again to prevent dehydration. Now fluid therapy in severe dehydration, the 100 ml per kg which we said, we need to give the first 30 ml per kg and the next 70 ml per kg in a different way. So in a child less than 1 year of age, first 30 ml per kg is given over 1 hour, next 70 ml per kg over 5 hours, so total 100 ml per kg over 6 hours. While in a child more than 1 year age, you can give in half of that time. So in half an hour, you give first 30 ml per kg, 2.5 hours, next 70 ml per kg, and total 100 ml you can give over 3 hours. Okay. So our child in the given question has got some dehydration, we said, right? And there is no vomiting as such. So you can give orally ORS. And how much needs to be given? We mentioned it is 75 ml per kg over 4 hours, right? The weight of the child in the question mentioned is 8 kgs. So what is 75 into 8? So 75 into 8. So here we need to give 600 ml fluid over 4 hours, right? Right? 600 ml over 4 hours. Now 600 ml 4 hours, that means in the first hour how much fluid you are going to give? 600 divided by 4, that is 150 ml, and it is to be given in the form of ORS because there is no vomiting, the child can take orally. So the best answer to this question requiring a little bit of maths on your part is 150 ml ORS needs to be given in the first hour, right? So I can see still Kratika, Yashika, Rajendra, Partha, Avinash, Akshay Rajput, Ghanshyam, you've answered it correctly. So it tests many important concepts. This question, how to assess dehydration in a child with diarrhea, what is the fluid therapy to be given, how much fluid is to be given, which fluid is to be given, at what rate is to be given. So treatment of acute diarrhea in children, I'll just like to mention there are 3 things. What are they? So one is you continue normal diet. So in acute diarrhea, you need not stop milk or any other thing from the diet. Continue normal diet, but of course, if you are giving chips and kurkure, that is not a normal diet. That should not be given. Okay. So continue normal diet. What else? You need to give WHO ORS. Okay. Either to prevent dehydration as a replacement of ongoing losses, or to treat some dehydration, or if there is some severe dehydration, you need to give IV fluids. And the IV fluid of choice is RL, Ringal lactate and 5% dextrose. Okay. And you need to give zinc therapy. Zinc has been seen to decrease the duration of diarrhea, also prevents the recurrent episodes of diarrhea, helps in mucosal healing. So zinc in a child 2 to 6 months of age, you need to give 10 mg per day. Okay. While in a child more than 6 months of age, you need to give 20 mg of zinc per day for a period of 10 to 14 days. So that is the treatment of acute diarrhea in children. Very, very important, must know area. And the composition of WHO ORS again is very important. The osmolarity is 245 milliosmoles, okay, and it has a sodium of 75, glucose of 75, potassium of 20, chloride of 65, citrate of 10. So the composition of WHO ORS or the reduced osmolarity ORS, which has a osmolarity of 245, very, very important for you to know, right? Moving ahead, a 4-year-old child who presented with generalized edema and ascites, there was no hypertension or hematuria. So only generalized edema is there, no hypertension or hematuria. Renal function tests were normal, massive proteinuria is there. So this appears to be a case of nephrotic syndrome. Nephrotic syndrome, friends, we know is a condition where there is generalized edema, massive proteinuria, right? Hypoalbuminemia and hypercholesterolemia or hyperlipidemia. And this massive proteinuria you can categorize in children as a UPUC, urine protein by urine creatinine of more than 2, right? UPUC more than 2. And the most common cause of nephrotic syndrome in children is minimal change disease. And so this does not appear to be membranous glomerulonephritis. This is not a nephritic kind of a picture. Minimal change disease is the best answer. Nupur, Lalita, Arvind, Sanket, Gansham, Avinash, Rajendra, Monica, Shroshta, very good guys. Arun, Akshay Rajput. So post-streptococcal glomerulonephritis would present as nephritic syndrome, where the hematuria, cola-colored urine, hypertension will be more common. The edema will not be so severe. Proteinuria might not be massive. It will be nephritic range in nephritic syndrome. In post-streptococcal glomerulonephritis, you can get an antecedent history of sore throat or skin infection. IgA nephropathy also usually presents with hematuria 1 to 2 days following a sore throat, right? So the best answer is minimal change disease. Now, before moving to the next question, nephrotic syndrome, a must-know area for you. Guys, go through the, we know that in light microscopy, you'll get no findings in minimal change disease. Electron microscopy, you can get flattening of the foot plate of podocytes. Then what else you need to know about the treatment of nephrotic syndrome? The drug of choice is prednisolone for the first episode and recurrent episodes. Then there can be steroid-dependent nephrotic syndrome, where alternate day prednisolone is required, or you may use levamisole or cyclophosphamide. Then you also need to know the treatment of steroid-resistant nephrotic syndrome, where you need to use calcineurin inhibitors in the form of cyclosporin or tacrolimus. Okay, very important. Moving on, most common cause for urine flow obstruction in a male baby. So urethral atresia, no, it is not so common. Uterocele is also not so common. Posterior urethral valve or PUV is very, very common. In fact, it's the most common cause for urine flow obstruction in a male baby, and not anterior urethral valve. So the typical case scenario that you get is that the mother can complain that the baby has straining during micturition. He puts a lot of force before passing urine, and you may also get a history of interrupted or impaired urinary stream. The urine does not come out as a proper stream. It may come, as an interrupted stream. So posterior urethral valve is a very important condition. It requires fulguration of the valves. If not done in time, you can have, reflux induced nephropathy can be there, and the babies can develop even chronic kidney disease secondary to it. So very important entity, posterior urethral valve, you need to identify from a given case scenario. Again, many of you have answered it correctly. And moving on to our last question, which we are going to discuss today: which disease has impaired collagen synthesis? We all know in rickets, there is a defect in the mineralization of bone, nothing to do with collagen as such. And in rickets, nutritional rickets is mostly due to vitamin D deficiency. Guys, read up rickets, very, very important topic. The clinical features of rickets, you get frontal bossing, parietal bossing, rachitic rosary, wrist widening and all that. And the biochemical features: calcium phosphate usually low, alkaline phosphatase elevated, vitamin D low, PTH high. In nutritional rickets, X-ray findings of rickets, very, very important: cupping, fraying and splaying of long bones. Scurvy is a disease which has impaired collagen synthesis, because we know scurvy is due to vitamin C deficiency, and vitamin C is required for collagen synthesis, and collagen is the backbone of blood vessels. So you can get case scenarios where there can be gum bleeding, and exclusively cow milk fed baby, because cow milk is deficient in vitamin C. You can get painful pseudo paralysis of lower limbs because of the subperiosteal hemorrhage of long bones. So scurvy, my friends, is a condition where impaired collagen synthesis is there. Again, lot of important radiological features of scurvy that you need to know. So there's that Wimberger sign, the Pelkins purse, Trummerfeld zones. Just go through it once again before your exams. Beriberi, is due to deficiency of thiamine, so that is not the answer here. And night blindness is often seen in vitamin A deficiency. Vitamin A, friends, the dose of vitamin A is very, very important. We know less than 6 months of age, it is given 50,000 international units per dose, right? 6 months to 12 months age, the dose is 1 lakh international units per dose, and more than 1 year of age, it is usually 2 lakh international units per dose. And for therapeutic dose, we need to give it at diagnosis, 24 hours later and 2 to 4 weeks later. So the dose of vitamin A again is very, very important. The staging of various features of vitamin A deficiency: night blindness, the earliest symptom of vitamin A deficiency; conjunctival cirrhosis, the earliest sign of vitamin A deficiency. So also read up the micronutrients, very, very important. Usually nowadays you get 1 question or 2 from there. Okay. So these are some of the very, very important topics in a nutshell. So all the very best to all of you, and I'm sure you will come up with flying colors. So with less than 1 week remaining for INI-CET, it is the time to focus and focus. Do not go to read something new at this time. Just keep on revising all that you have read, okay? And with the NEET PG also going to come up very soon, stay focused. Work hard, be sincere, believe in yourself, and I'm sure you will achieve all that you've dreamt for. I hope you have benefited from this session. If you have, then after this session ends, do message me how you like the session. Okay, your feedbacks are very, very important, very valuable for me. And all the very best to you. God bless you. Have a great day and a wonderful time in your exams. Get all that you ever wanted. All the best. Signing off. Thank you, friends.